This is Jason Gerling with Navigant Consulting. We currently work with the Alabama Medicaid Agency around implementation of the integrated care networks, and I'm joined by several colleagues and agency staff here today. We're pleased to be having this webinar. It's a continuation of a really effective meeting that we had with the association leadership a couple of weeks back, where it was brought to the agency's attention that there was a lot of interest and renewed focus on the integrated care network program. And so this morning our intention is to really provide a strong summary for those hospitals across the state who are currently examining this program and what impacts and reforms are to come. And so I'll move to the next slide and we will cover what our goals are for the day. And so within the next hour and a half, we're going to be reviewing the national landscape for managed long-term services and supports implementations. And also reviewing coordination for dual-eligible ICN members. It was brought to our attention by the association that there are currently some efforts to build provider networks around dual special needs programs, and so we certainly want to delineate between those programs and what the integrated care network will serve as, so that you have clarity around the two different business models and we reduce any confusion that may exist currently. We're going to be describing the integrated care network model and the targeted population that will be served by the program. We certainly want to review the goals of implementing an integrated care network and really moving into a managed long-term care delivery system. Summarize some of the external reasons why this reform is needed in Alabama, and certainly want to give you some insight as to, at the federal and state level, why change is really critical, much of which I think will resonate with you all as acute care providers. And then last but not least, provide some next steps and action items, acknowledging that this is a long implementation process, but we need all provider types to be really highly engaged and play a role in developing the program and getting us ready for success when we go live in 2018. We'll also be leaving some time at the end for questions. And so what I'll ask is that all folks, as questions arise, just make note of them, but we're going to ask folks to please just refrain from asking questions during and just wait until that established question and answer period at the end of the presentation.
I just would also note that this session is being recorded, so this will be something that will be available for further consumption post the conversation today. And as we approach the question session, you'll want to unmute your line so that we can hear those, but otherwise please keep your phones on mute.
All right, so the national and state landscape for managed long-term services and supports. MLTSS is sort of the magic acronym, and you're going to hear it in the ICN program development process quite often. Managed long-term services and supports is a concept and a service delivery model that has expanded quite a bit since really 2010. So this is the current map of MLTSS program status across the country. And this was published by NASUID, which is the National Association for State Units on Aging and Disability, who provide Alabama plenty of subject matter expertise in this area. But you'll see that there is a strong representation of statewide MLTSS programs across the country, really in each region of the nation. And Alabama is highlighted in green as one of the states that, starting in 2015, has really expressed interest and began the process of building an MLTS model for their state. And so you'll see that certain states also have programs in active development. Pennsylvania is really the largest program right now that's sort of pending a go live. You'll also note that certain states are represented with regional programs. And so there is a blend of different types of scopes. But really, all of these offer long-term supports and services delivery under Medicaid through a managed care type delivery system. Next slide, please. So what is MLTSS? At a high level, MLTSS moves delivery of Medicaid-funded LTSS to a capitated payment model for state plan and waiver funded services. And when we say LTSS at a broad level, what that really means is that Medicaid is responsible to pay for two real buckets of long-term care. So skilled nursing facility or nursing home care, of course, is the predominant one in this state, but then also we have home and community-based services, which are certainly growing nationwide. I think last year was the first year where more was spent on home and community-based services from a national vantage point than on nursing facility care, which is exciting. But certainly, the home and community-based service delivery occurs through Medicaid waivers within the state of Alabama. That's not a state plan service, but that's what we're talking about when we speak to LTSS on the whole. 8 states incorporate a comprehensive menu of services where in their managed LTSS delivery system, those managed care entities are responsible to deliver and at risk for both the long-term care services that their members receive and then also their healthcare services. So that would include your primary care, your acute and subacute care, et cetera. So you'll see that 12 states offer a MLTSS program that is separate from its managed medical care package. Florida is one state that does that currently, where there are 2 separate managed care providers. They attempt to align in a lot of those states, but one managed care entity will be strictly responsible to manage the LTSS care plan and delivery of services, and then you'll see that the other aligned managed care entity is more of that traditional healthcare delivery model where they're focusing on, again, acute, emergency room, physician, specialty, et cetera, care that is needed by members. And so those programs don't put the whole network of services at risk.
And I would just add, too, there are other states. Pennsylvania's model is where the full integrated package would be managed by a managed care entity, but only for those individuals in need of long-term supports and services. Iowa is an example. They recently launched their program. They have one managed care program. So whether you are an individual in need of long-term services or not, it's one health plan who's managing that entire population, which is inclusive of both managed and long-term care, or traditional and LTSS. So to put it in Alabama terms, we have separate models where we are looking to implement the RCO program, which is very specific to a population who is not in need of long-term supports and services, whereas the ICN is intended to be an integrated service delivery package, but only for those in need of long-term supports and services.
Some other things to note is that only 5 states have included the intellectual and developmental disabilities populations in their program to date. Alabama's intention is to exclude those populations at this time, and there's several reasons why that population is often left to enter into a managed care delivery model later on. For states that are less sophisticated or experienced with managed care, that's a real high-risk population with a highly specialized set of services and a very visceral and very strong-minded group of advocates. And so oftentimes those populations are left to last once the system is really evolved and is operating on all cylinders. It's just not a population that you want to test pilot with. And so the key focus areas of MLTSS programs tend to include driving long-term care rebalancing. And so rebalancing, for those who are not familiar with the term, refers to the intent to balance the system such that you are providing on an equal playing field nursing home care to home and community-based care, which is a long trend from sort of yesteryears where long-term care was delivered primarily through nursing home and institutional-based care. Improved care coordination is another real key focus area, and reducing preventable expenses, including unnecessary institutional care and also preventable hospital and emergency room utilization, often tend to be high focus areas for an MLTSS program. So then we'll move to what a dual eligible special needs plan is, or a D-SNP. And so this is where we are aware there has been some confusion for many of the hospitals across the state because you're currently being approached to enroll with a D-SNP, thinking that you might be enrolling with an ICN. And so we really just want to delineate between those two models so that there's clarity around what the Medicaid agency is doing compared to third parties that are out there trying to build networks around these dual special needs plans. So dual special needs plans are Medicare Advantage products that provide a coordinated Medicare and Medicaid benefit package and offer a higher level of integration than a typical Medicare Advantage plan or traditional Medicare fee-for-service. So essentially, this is Medicare Advantage geared towards those individuals who are dual eligible and receive Medicaid, acknowledging that that population is high risk and low income. And so certainly you want to gear your care coordination and your networks and your service delivery to really address some of the unique challenges with that population. Dual special needs plans are not new to the state of Alabama. In fact, you all have a pretty robust enrollment within the state. So as of December 2015, there were 305 contracts or 541 plans in 38 states, with a total enrollment in excess of 2 million members. In Alabama, there are 4 dual special needs plans run by Cigna, Viva, United Healthcare, and Humana. So you may be working with any of those or contracted with any of those plans right now, and you'll see the plan enrollment numbers reflected in the table as provided. And you'll also note that each plan has a specific geographic area, which plays a role in how these D-SNPs will play a role in the ICN program. Because the ICN program as a Medicaid program will be statewide. There will not be a regional coverage. It's going to be every county in the state, all members of the state who are Medicaid and eligible for long-term care. At the bottom of the table, you'll see that United Healthcare also has what's called an institutional special needs plan, or an ISNP. Institutional special needs plans are special needs plans geared towards coordinating Medicare and Medicaid benefit packages for individuals who reside in an institution. They characteristically are limited in their geographic coverage, and so you'll see that United Healthcare has a small plan with about 490 members. And so that is really the mechanism that many states use to help coordinate between MLTSS programs. And then for members that are coming into that program that receive a lot of their health care through Medicare, there certainly needs to be a mechanism to make sure that although Medicaid is not the primary payer, there is adequate coordination and adequate collaboration with providers who really have expertise in delivering Medicare-funded services, acknowledging that acute and physician care plays a really heavy hand in how folks, come into the long-term care system, but then also what long-term care they require and, to what degree, extent, and duration they require it. You really just need to make sure that that medical care is coordinated regardless of the payer.
I want to jump in. A couple of points I just want to emphasize around the dual special needs plans. Jason has mentioned that they only cover the Medicare benefits. And so those Medicare benefits are not long-term care benefits. What is interesting for states as they look to implement a Medicaid managed care plan is that while those D-SNPs aren't covering long-term care services, because their emphasis is on the dually eligible, they tend to have a real connection to the population that will become part of that long-term care design. So there is certainly a lot of focus on, is this an advantage point for us or not? Alabama has declared that there isn't an expectation that the ICNs must be a D-SNP, and to date there's not a guidance to say that they have to coordinate with a D-SNP, but there is certainly guidance to say that the ICNs will need to coordinate those Medicare services with whomever is delivering that benefit for the population that will be part of the ICN program. I also wanted to note that I think some of the folks that you all have been receiving inquiries from are not listed here. And that is because those entities are seeking to become a D-SNP. They are not yet a D-SNP in the state of Alabama. So with that in mind, I think I would highlight as my final comment on this slide. You'll see with those who are D-SNPs in Alabama, they operate in very specific geographic areas. And that's an expectation of that application process, is that the organization defines where they want to stand up their D-SNP. So what's interesting is that our ICN program is a statewide program. And so there is some thought about a new entry of a D-SNP looking to mirror that ICN requirement. That is their business decision. That is nothing that is dictated by AMA. But that is an aggressive model. Across the country, we do not typically see that a single D-SNP is functioning in that state on a statewide level. But that's kind of where they are in their application process, is in order to achieve that, so to speak, accreditation from CMS, they have to demonstrate that they have an adequate network, and they're in that cycle of their application where they need to build the network, but it is separate and apart from what we're doing on the ICNs. So just a couple points to kind of help provide hopefully some clarity around what's going on in the marketplace today.
And so we'll just accentuate that with this last slide and refer to the key concepts document, which is available on Medicaid's website, which declared some of, in September, the agency's decisions around program design at a high level. So some of the points that we just want to highlight before we leave this coordination of dual eligible members topic is that roughly 80% of the ICN population that we project to have at Go Live are dually eligible. So coordinating between Medicare and Medicaid is going to be really critical. For this group, the majority of their healthcare expenditure will be paid by Medicare. That's simply a reality of the relationship between Medicare and Medicaid. Medicare is the primary payer, Medicaid is the payer of last resort. And there's a lot of overlay between how the services that are delivered through Medicare would potentially impact the services that are needed and then funded through Medicaid. And so we certainly recognize that it's critical that there be some collaboration and coordination between those two insurers and payers. Regardless of payer, proper coordination of members' healthcare services is going to be a significant driver of LTSS because, again, 100% of your LTSS is pretty much paid for by Medicaid for these members. So everybody's got skin in the game when it comes to Medicare, Medicaid, and those respective payers. The key concept decision that was landed on by the Medicaid agency is that while the agency will consider all different types of models in order to coordinate between those members that are dual eligible, a D-SNP is not going to be the required model. So if an ICN, because we'll be doing a competitive procurement, submits a bid, they will in that procurement process have to attest to their model for coordinating Medicare benefits and Medicare services for their members. That can include, we're going to have a D-SNP that we partner with. However, there could be other models. And you may ask, well, if D-SNP is an established program, why wouldn't you just mandate that? Which is a fair question, and it's something that we certainly kicked around. Where we really landed is that the reality of the D-SNP application is that in order to be approved to offer that product, it's a very rigorous, lengthy application. We're not going to be procuring ICNs until middle of this year. And so the reality is, if those ICNs wanted to newly establish a D-SNP, they would have had to start that application last fall. Thus, the timing of applying to become a D-SNP and then bidding to become an ICN don't align particularly fairly in order to offer all possible bidders an avenue to go ahead and submit a bid and demonstrate how they would coordinate those services for Medicare. So we did decide that it's an option, certainly one that we will consider favorably. But that being said, if folks could please just mute their lines. It's one that we are not going to mandate for all ICNs, and it will not, if you opt not to contract with a D-SNP, preclude you from contracting with an ICN. So what is the ICN model? So the Integrated Care Network legislation that was passed has several key elements from it, and I think that this is helpful both to see where the ICN program is similar but then also different from the RCOs. So the legislation allows for one or more integrated care networks. They will be provider-sponsored plans that are at risk for comprehensive Medicaid services. So we will be joining those 8 states that I mentioned that offer a comprehensive package where both your health care and your long-term care benefits will be coordinated and at risk. ICNs will operate statewide, so we will not take the regional approach that RCOs have. The network will be statewide, coverage will be statewide, and so the only thing that mirrors the RCOs is that there is some language that indicates that you will need, as an ICN, to have local offices in all 5 of the RCO regions. It will require a competitive procurement process, which is a significant difference from how RCOs were established. And then the profit status is to be determined, but at this time it is not required that ICNs will be nonprofits. And last but not least, ICNs are applicable to recipients who are not covered by RCOs. Dual eligibles are excluded from RCOs, as are long-term care recipients. And so the reality is there's a very clear delineation between whether you would be an RCO member or an ICN member, and you will not be able to be served by both at the same time. So who is the target population of individuals that we anticipate enrolling into the ICN program? So populations either in nursing home long-term care or home and community-based waivers that have nursing home as their institutional equivalent. So we'll refer to that as the nursing home level of care eligibility standards. So those HCBS waivers include 5 waivers that you may or may not be familiar with. The elderly and disabled waiver is the state's largest waiver far and away. And so 93% of the nursing facility level of care population in a waiver are on the elderly and disabled waiver. That provides things like home delivered meals, personal care attendance, respite, etc. But there are other waivers included that we anticipate being rolled into the ICN program along with their service menus. So that includes the Alabama Community Transition Waiver, the ACT waiver, which was implemented to allow an avenue for individuals who reside in an institutional setting to transition back to community, the HIV/AIDS waiver for individuals with that specific diagnosis, the State of Alabama Independent Living Waiver, the SAIL waiver, which is a waiver targeted to individuals with specific diagnosis that may be equipment dependent, so musculoskeletal issues, muscular dystrophy, ALS, certain high risk, high needs populations and diagnoses with difficult prognoses. And then last but not least, the technology-assisted waiver. So the technology-assisted waiver are individuals who are not eligible for EPSDT because they've aged out of that system, but do require private duty nursing in order to remain in a community-based setting. And then again, the other target population that we anticipate rolling in are individuals that reside in a nursing home on a long-term basis, which is essentially by the eligibility standards we are using today, 90 days or greater. RCO and ICN programs, again, will be mutually exclusive in membership. The commonality will be that individuals transitioning from the RCO to the ICN will have to demonstrate and be physician certified that they meet Alabama's nursing facility level of care. So how large is that population? So what we show in this slide rather, is that there are really 2 layers to the system. There is capacity. So you'll see on the left that the long-term stay nursing home residents have 27,006 statewide beds. In fiscal year 15, that translated to an average recipient load of about 16,189 individuals on average residing long-term in a nursing home. So you'll see that there is some capacity available in that system. And then when we move to the home and community-based service waiver participant numbers, there are 10,255 slots designated by CMS and approved across those 5 waivers that we just described for you. In early 2016, the enrollment stood at just over 7,000 members. There was a redistribution of those slots in 2016 in order to maximize enrollment, and so you'll see that enrollment jumped to nearly 9,000 by October 2016. And so as far as capacity goes, when we add up available beds and waiver slots, we have room theoretically in the system for a little over 37,000 members. We estimate membership at Go Live in October of 2018 to be roughly 25,000 members. So this is not a large group per se when you look at patient load, but it is a high consumption, high cost group. So it's really critical that we hone in on this population and really establish different methods that are different and better to care and coordinate care for them. So when we talk about this comprehensive menu of services, at a high level, what we speak to is within healthcare, we're looking at hospitals, emergency rooms, lab and radiology, primary and specialty care, home health, hospice, behavioral health, and vision. And then in long-term care, as we've spelled out, nursing homes and home and community-based services. The one note that I will draw your attention to is that pharmacy will remain a covered benefit under Medicaid fee-for-service. This was also done in the RCO program. That being said, although ICNs will not be at risk for pharmacy, it will be a very high priority for them to coordinate that service. Polypharmacy has been identified as a huge issue with this population. It's a big contributing factor to utilization of both health and long-term care. And so there is no way that you could leave pharmacy out of the mix and expect to be successful with this population. So the idea is to really blend all of these services into one comprehensive menu that is singularly coordinated with the goal of improving quality, access, and sustainability for members.
And I think it's very easy to lose a little bit of perspective when we show this slide. We mentioned earlier that 80% of the population that we anticipate to be part of the ICN program are dually eligible. So on those things that are listed under Medicaid healthcare, really only 20% of the population will get this full menu in terms of being at risk by the ICN. But similar to Jason's comment about pharmacy, the expectation of the ICN is that not only are they coordinating pharmacy, which we know that regardless of whether you're dually eligible or not needs to be coordinated, all of these services will need to be coordinated for those who participate in the ICN program. And I think it's important to recognize that a lot of those Medicaid healthcare benefits will be covered by Medicare, and that's where that coordination with the Medicare Advantage plan, whether that's a traditional Medicare Advantage plan or a D-SNP, and also understanding that the way those groups operate here in Alabama is that you might be having to coordinate with multiple groups, or the ICN will. And so that's just an important consideration, and I think for those of you on the line, you represent the deliverer of those services or the provider of those services. And so understanding that there will be continuity for some of this population with those Medicare Advantage plans, with those D-SNPs, but you'll also have another coordination function with the ICNs.
So just another breakdown of the at-risk services that an ICN will be responsible to deliver. So you'll see that what we did in this slide was highlight those services that are co-paid for by Medicare, where Medicare is the primary payer for these services. And so you'll see that there are a number of services that, again, offer that Medicare overlay, where Medicare will still be the primary payer of that service. The ICN may not be taking on considerable risk for the whole population specific to some of these services, but the reality is it's really going to be important that all of these services get properly managed. And you'll see that the 3 services where Medicaid is really the sole payer is HCBS waiver services, nursing home care, and non-emergency transport. When you look at the total spend for Medicaid for this population, about 90% of the dollars that go out for individuals within the ICN population go towards these 3 services that are not highlighted. So it's really critical that we hone in on better ways to deliver that care. And then for folks who are less familiar with long-term services and supports, I know that it's helpful to get a sense of what might be on those home and community-based service waivers. So this table offers you a sort of sampling of the types of services that are available to individuals on the 5 waivers that we've indicated. And so that would include things like private duty nursing, personal assistance service, homemaker, home-delivered meals, adult day programs, environmental adaptation and assistive technology, personal emergency response units, or as you might know them, lifeline buttons, adult companion services, both skilled and unskilled respite, case management, and medical supplies. And so really there is a broad swath of provider types and a lot of different types of services that when we talk about home and community-based services roll in to that delivery. And so what we've highlighted is that under all of that, and one of the things that we have heard from stakeholders in the comprehensive stakeholder sessions we've held throughout the state, particularly with consumers and caregivers, is that there is a gap that exists today between primary care and accessing these services. We have had many Medicaid members tell us that primary care never talked to them about long-term care or steered them towards nursing homes. Or demonstrated lack of understanding about home and community-based services or a lack of partnership with today's home and community-based care. But really the idea in a managed care delivery model is that that primary medical provider would play a more in-depth role in helping to formulate and identify areas of opportunity in that long-term care plan, really to sustain members when they're not in the physician's office, such that you can really manage their long-term care, but also their chronic disease management, and really maximize any opportunities for self-management where you can. So that's really what we try to depict in this table. But one thing that really underlies this diagram is that establishing an adequate network of all of these different types of services is going to be a heavy lift for the state. It is something that today is lacking in many parts of the state, including when it relates to primary care. So that's something that in planning we're cognizant of, and certainly is a point of awareness and concern, is that there's going to be a considerable need to drive more providers being willing to contract with ICNs and provide services through this delivery model than exists today.
And I would just also kind of emphasize here, with the concept of the ICN program and the goal for comprehensive integrated service delivery package, the care coordinators are going to be taking on a very different responsibility. And so for you all who are on the phone, again, I think in that discharge planning process, as while your case managers for HCBS should be part of that today, they're very focused on what you see here on this slide, what's available within the waiver for this particular individual. But that focus is going to be broader because that at-risk set of services is broader. And I think a lot of hospitals are starting to feel some of the pain around avoidable readmission penalties from Medicare. And so this does represent an opportunity for that collaboration and for you all to be thinking about. Not that doesn't exist today. Again, I'll emphasize this is a new window. But I do think because of the skin in the game that comes with this type of at-risk program is something to keep in mind of how you're going to coordinate with those care planners and their case managers throughout this process.
And so we'll just look at expenses and trends. So you'll see that from 2010 to 2015, and I want to note here that the actual growth in members has been pretty flat. But you'll see that regardless of a flat growth trend as it pertains to enrollment, growth for costs has continued regardless. And so from 2010, you'll see that there's been about a roughly $100 million increase in total Medicaid expenses across all of the Medicaid care that's provided. How that translates out to a per member per month is that you'll see that there's been roughly a $500 increase PMPM from 2010 to 2015. So what that tells us is that controlling membership or managing enrollment is not going to be sufficient to really curb the tide as it relates to long-term care delivery and the fact that we've got a demographic explosion, but also a cost explosion before us. So we really have to, again, look at other methods to deliver these services such that we can bend the cost curve, so to speak, and really sort of control some of this swelling that we've seen over time. So what are the goals of ICN implementation? And really at a high level, we have three goals: quality, access, and cost containment. So within quality, what we want to see by shifting to the ICN model is an increase in community inclusion for LTSS recipients and allowing for aging in place, which many tell us today is a challenge for them. They don't have a strong alternative to a nursing home available to them in the community. If folks could please just mute your lines for me. We want to include person-centered approaches that address both the needs and wishes of the beneficiary. That's not simply a Alabama Medicaid principle, that's a federal principle that's heavily reflected in all the work that's being done nationwide in long-term care. We want to reflect the values of dignity, respect, and quality of life. So we don't just want folks to have good health care. We want folks to have a better day-to-day experience and avenues to more purpose-driven living. And then demonstrating clinical best practices in service delivery across the continuum. So that would include, acute care, primary care, and long-term care. As far as access goes, we want to include high-quality care coordination that really offers a broader liaison for beneficiaries to the care and services that they need. The case management and the care coordination that is offered today is very segmented and environment specific. And so we want to really avoid the environment where you're only talking to a discharge planner in the hospital, your case manager's on hold, and you won't talk to them until you've been discharged. We don't see that as an effective model that's particularly fluid for consumers. We certainly need to drive enhancement of the provider network to establish this comprehensive service availability throughout Alabama. And then, of course, we need to increase access to preventative services and early interventions. Folks come into the system today at a very high acuity level where it's almost difficult to do much to really help them recuperate or stabilize. And so we really want to get folks into the system at a place where they have a long-term care need, but it is not so severe that we can't maximize improvement and betterment for quality of life and quality of care. And one of the things that we have to prevent is premature institutional care. It carries a very high cost and certainly is not what consumers are asking for. They want options within their home setting if they're available. I think that we can all appreciate, if we've ever navigated this journey for a loved one, that is the preference for many of us as it relates to our own family. And so we need to offer that to some of our most vulnerable and needy in the state. And then last but not least, cost containment. And so we're going to contain costs through reduction of preventable utilization, through value-driven care, and by using a team approach that really drives cross-provider collaboration and gets us out of silos where there's a lot of duplication and, again, preventable expenses of healthcare utilization. And cost containment is the word. It is not savings, and I want to make that point because, it's been floated out there that the ICN would be a cost saver. It's just not feasible to think that with the growth in healthcare costs and the fact that demographics with this aging population that is coming down the pipeline are going to allow us to save any money. If anything, we just have to be better budgeters because we recognize that there are a lot more folks coming into this system and that's not going away. So to anticipate savings is not particularly practical. So cost containment is really our focus. So why change the system? And really at a high level, the top reasons for why we need to change the system is because there's increased demand for LTSS, which I've described, and there are federal requirements that the state is susceptible to and has to really focus in on meeting. And I know folks have asked, well, you've got a change in administration right now. Do you envision that really changing the federal requirements? And some of these requirements were really introduced back in the George W. Bush administration. So this is a bilateral commitment to really changing the way that long-term care is delivered. I'm highly doubtful that a Republican administration is going to really undo a lot of the work that has been done in this area in the previous administration. But all of it does funnel into the need for Alabama to really look at what in this state needs to be done to start moving the needle on transforming the long-term care system. So the national data, and this is in the healthcare world, information that you probably are already aware of. I think it's always helpful to see it enumerated, but you'll see that there are several forces that are sort of merging into driving increases in federal spending for Social Security and major healthcare programs. And so this Congressional Budget Office diagram shows that really the aging of the population is a huge driver of that, but that also just the growth in spend per capita on healthcare also creates sort of a perfect storm. Expansion of healthcare programs, you'll see, plays a lesser role. Really, at the end of the day, it comes down to people and dollars that are driving a lot of the growth in this area that's got to be controlled. And you'll see in that middle diagram that Medicare is going to really exponentially increase as a part of the federal budget, which is certainly cause for concern both at the federal and the state level. But you'll see on that bottom line that Medicaid is increasing as well. So in a state like Alabama, where this has not been a strong year for the budget conversation, we have to be mindful of any and all drivers of cost that are going to increase, what the state has to pay out in order to sustain Medicaid services for members in the state. And then that last diagram is simply a depiction of the growth in the aging population. I will make note that individuals 65 and older are a big part of who we serve in long-term supports and services, but it is not the whole of whom we serve. That being said, the fact that people are living longer and are living longer with chronic diseases, regardless of age, are just a huge contributing factor to the demographic swing that really forces the hand of state governments to get their mitts around how best to control the costs related to long-term care. So how does that translate to Alabama's picture? So if we project the growth of the 65 plus population in Alabama, and then we pair that with CMS's projections for healthcare inflation rate, Alabama's Medicaid spend, and that's the total spend, so both federal and state shares, for the current long-term care system would increase 10 times. So it's about $1.05 billion today. And that would skyrocket to $10.4 billion in 2040 if we left the system alone and didn't change anything. And so clearly that $10.4 billion is simply an unmanageable number that is never going to be palatable to taxpayers in this state. And so certainly we have to now look at what can be done to nip this type of growth in the bud and really get a better system in place that is sustainable. Because this type of a growth pattern is not. And last but not least, what are the federal influences on long-term services and supports reform? And really at a high level, and I'm not going to belabor this with a lot of details, but in the process of designing the ICN, we continually sort of cross-reference back to the need to be compliant with these three sort of high-level regulations or laws related to long-term care and individuals with disabilities. I think the Americans with Disabilities Act goes without saying. It's been around for 30 years now. And so the notion is that the ADA was designed to increase access to community participation, all of the same day-to-day living and opportunities that you and I have as non-disabled individuals have to be equally available to individuals with disabilities. And that has, I think, propelled into what on the healthcare side was the Olmstead decision, which occurred in 1999. It was a case that occurred and came out of our neighboring state of Georgia. The Olmstead decision essentially says at a high level that no more can states offer all of their long-term care in an institutional setting. If individuals are willing and able to live in a community-based service setting, then we need to offer them an equal opportunity to live in that community setting and not force them institutionally to receive their care simply because we're not willing to offer or pay for an alternative. And so that's something that has driven a lot of change and service innovation in long-term care since it was decided in 1999. And then last but not least, the 1915 CNI waivers. These are Medicaid waivers that allow the state to design specific waivered services that are specialized to certain populations that may not be available within the state plan. That 1915 C and I waiver authority has a lot of stipulation attached to it that when you apply for a waiver, which we will be applying for these waivers we'll be applying for a 1915C waiver in order to get the ICN program approved by CMS. Certainly has attestations required that show that the state has commitment to person-centered care, community inclusion, offering a real alternative to nursing home care. And so we recognize that in order to get this blessed federally, we're going to have to reflect that in our program design and make sure that we really present a program that offers expansion of home and community-based services and a meaningful alternative to individuals in a community-based long-term care setting. And so I will bring you to the ICN implementation time frame. So we've been in the planning process since 2016. I know a lot of folks in the healthcare system that are not really as deeply tied into the long-term care system are immersing themselves in this right now. There is a lot of public information available. This has all been a very public process. I think the challenge that we have had is between the budget and between the RCO implementation, ICN's got backburnered, but clearly, as you can see in today's presentation, you all are a very important part of the network and the service delivery system, and so we certainly welcome you to the table. In 2016, we spent the bulk of that year in conversations with other states, really making key concept decisions, and stakeholder engagement was really the focus of 2016. Alabama Medicaid has done a lot to get out on the road and learn about the current system, get the perspective of members, and that is not simply a goodwill exercise. That is a requirement of CMS. They expect to see stakeholder engagement, the ability of the state to educate members on the changes to come is going to be a really critical part of whether or not we are greenlit for go live federally. So that was how we spent 2016. Now here we are in January 2017. We'll be releasing the concept paper, which really provides a lot of the nuts and bolts around what we envision the program to look like. That should be coming out in the month of February, and so certainly we want to encourage folks to stay tuned for that. There are a number of ICN rules that will be released in the early spring, and so those rules will be available for public comment, as will the concept paper. And then in the spring, we'll be, of course, be digesting and processing those comments such that we can really tailor the program design to the wishes of all of those parties that are impacted by the ICN program, both from a consumer but also a provider vantage point. In August, we anticipate going live with an RFP. And so in that summer phase, it will really be about issuing that procurement, finalizing the contract such that we can align it with the procurement. And so once that is released, then we will spend the late part of 2017 procuring. And so analyzing bids and determining who will be the selected vendors to become ICN statewide. And so that will move us into 2018, where those selected vendors will then be put through the readiness process to make sure that we are ready to launch. And this is not a group that trickles into consumption on go live. This is a group where en masse, they're all going to receive services on the very first day of ICN service delivery. So we've got to be primed and ready. And so The other really important part of this entire timeline, which is aggressive, is that we're going to be constantly offering public education, again, both to providers and consumers. We've got a lot of providers in this system who are much smaller than perhaps some of you all as hospital systems. And so they have different needs and different understanding and readiness for systems change. And so it's going to be a really critical component of program planning and implementation that we stay in constant communication. I will say that the state has been excellent about receiving and digesting information, and so we really want to continue that trend and capitalize on all of the good synergy that we've developed statewide.
And I would simply emphasize that while stakeholder engagement is in a box at the back half of 2016, that will continue throughout this process, is that it's not limited there. As Jason has mentioned, it's just such a critical component to implementation of a program like this. So while our primary objective is a little different as we move into 2017 and 18, that stakeholder engagement will continue throughout.
And so just to clarify before we move from this slide, as there are conversations related to network development, and again, just to emphasize that one of the goals of this call was to really help diminish some of that confusion. There are no approved integrated care networks today. That will be done via procurement, and there will not be approved ICNs until the end of the year. So you should not be approached to agree to participate with an ICN until those procurements have been completed and decided. So that's just something that we want folks to feel clear and comfortable about, recognizing that we want it to be as transparent as possible and crisp and clear, since there are so many programs that are coming down the pipeline from the Medicaid agency. Certainly want to make sure that you are comfortable with the timeline and comfortable enough with the subject matter that you can make decisions for your organizations that really reflect what you've learned from the state. So what are the next steps? We are in the process right now of the Quality Assurance Committee meetings. We'll be making decisions on Tuesday, January the 24th. So those appointments were made in the fall. Each provider organization has appointed members. So what we really ask is that those appointed members please make it a point to try to attend in person, because you cannot vote for measures if you are not physically present. That's an Alabama passed statute. And so that being said, if you have questions about your QAC participation, if you have questions about the rules, Drew Nelson from the Medicaid agency is your contact. I know he'll be speaking with some of you today in Tuscaloosa if you're going to be attending that meeting. And so certainly we want folks to be as engaged in that process if you've been appointed that committee as possible, because of course the quality metrics are a key driver in the success of the ICN program. The ICN email list is live. Feel free to go to the Alabama Medicaid website and sign up for it. It will be a mechanism for release of the concept paper, which again should be coming out in February. Public comment will be requested and encouraged. We want to hear from folks early and often. If you submitted a certificate for collaboration related to the RCO, that does not apply to the ICN program. So we certainly encourage folks, if you completed a collaboration certificate for the RCO program, you may want to go ahead and undertake that exercise for the ICN as well, so that you can fall under some of that trust protection. And then last but not least, submit all your ICN questions and requests for additional information to icninfo@medicaid.alabama.gov. There is a live human that reads those emails. We get them, we pay attention to them, and we certainly appreciate any and all questions. We would rather spend our time answering questions than resolving confusion.